Here is the structure of the bone we will see shortly. The microscopic anatomy we will see the bone. Here we will see the periosteum, the osteon. In osteon we see the canaliculi, the lines which nourishes the bone. These are the arteries and veins. This is the lamellae. Then this is the osteocyte, the cell present on the canaliculi. After that, here also present the Haversian canal. Haversian canal we will see here. This is the Haversian canal. It's provide the nourishment to each osteon, and this is the Volksman canal, which Haversian canal, and this is the Volksman canal. Volksman canal is between the two Haversian canal. It attachment between the two Haversian canal. This is the trabeculi of calcaneus bone. Trabeculi, these we are see here, and here we can see this is a compact bone. That's all. Bone highly vascular होती है. Then cartilage is no vascular, no regurgitation, and is limited. Here we will see the whole bone. In whole bone we will see the cartilage, proximal epiphyses, the growth lines. These are the growth lines here. The spongy bone inside the compact bone, medullary bone marrow, yellow marrow, periosteum. Outermost part is the periosteum. Sharpie's fiber present inside the periosteum. Arteries, this artery enter into the upward and downward. And Haversian canal we can see here. Haversian canal, and these two attachments also blood vessels, periosteum, osteocyte bone cells also present there. This is the proximal epiphysis, and here the endosteum, most common diaphysis, and that's we can. The previous slide we studied the general, and in general we see the salmonella diaphysis में करेगा, and pseudomonas infected with IV abusers में, and PN fungal करेगा, and human bites Aikinella, animal bites Pasteurella. In next we see the metaphysis plate. Here in the metaphysis plate the stasis turbulent and sluggish there. That's why the can stuck here. The in child the distal femur and proximal tibia fibula are most commonly affected, and in adults vertebra, and most common joint is knee joint, and in neonates this will be hip joint. In children 48 hours we should give the IV antibiotic, otherwise it will toxin inflammation spread to the limbs. Epidemiology we see the before the bone and joint infection from hematogen is spread, now less, and implants and the fracture replacement is more, and fixation and new source. Immunocompromised patient, for example diabetes and increasing sources, the many bacteria adhere to dead bone and implant surfaces, forming complex community enveloped in a polysaccharide matrix known as biofilm. These bacteria alter their metabolic state, becoming resistant to the host immune system and to the antibiotics. The infected bone reacts. The next slide is chronic osteomyelitis. Here we see the bacteria infecting bone form a protective biofilm. Then infected bone dies and form a sequestrum. The periosteum around lays down new bone. Sequestrum is a necrotic bone that is embedded in the pus or infected granulation tissue involucrum in cloaca. Sequestrum, it's a dead necrotic born, and involucrum is a newborn which occur, and cloaca is the opening which through a drainage of the bone occur. Okay, viral and gram-positive organisms, particularly Staph aureus, are the most common cause of the bone or joint infection in native tissue. However, once prosthetic material is implanted, a wide range of organisms can be involved. This includes organisms with low virulence that are usually considered skin commensals, such as coagulase, negative Staphylococcus, and propionibacteria. Biomarker raised inflammatory markers like erythrocyte sedimentation rate, like ESR, C-reactive protein, and CRP, like white cell count. Also, we will see if these are increased, then we can say that it will be infection, like septic arthritis, rheumatoid arthritis, or osteomyelitis, are cases of acute infection, and they are the neither sensitive nor specific. This just cannot rule in or rule out infection. These are not most time of the correct, but it will help increase WBC count, increase neutrophils and culture test, and before giving antibiotics, before taking culture, we should not give antibiotics. First culture, then give antibiotics. IV oral ESR, CRP, and WBC's count increases 4 to 6 weeks. We give IV for 4 weeks oral. We will give 4 to 6 weeks. We will give oral, and 4 6 we give of oral antibiotics. Here we will see the image. You can say hematogenous route via nutrient artery. Via nutrient artery, hematogenous route occur. The direct implantation secondary to trauma to surgery. जो direct implantation हुई है secondary to trauma to surgery. Here spread from infectious focus in contagious soft tissue. Here contagious soft spread from infectious focus in contagious soft tissue. Here from artery, and here in implantation. You can see this is the cloaca. This is the opening. Here the drainage will occur, skin, sinus, and involucrum. This is the involucrum where the newborn formation occur, and sequestrum. We can see this part here. Sequestrum, dead necrotic, dense white matrix. Biomarker and plain X-ray, we will see detect extensive bone loss and cannot be relied on, especially in early disease. Plain X-ray are useful in evaluating implant loosening and progression of chronic disease. Ultrasonography is ideal for this disease, and we will see the CT scan. That was the X-ray. Was the CT scan. Cloaca here opening we will see, and here MRI in CT scan. We first is CT AP view, lateral view, and secondary ultrasound, third CT scan, fourth MRI. We will see the defect medullary edema. We can see in early stage by MRI. Investigation of choice in osteomyelitis is MRI, and radioscopic bone scanning is valuable in early localization within 48 hours of bone infection. The specific radioactive isotopic imaging techniques have improved in the evaluation of musculoskeletal infection. Technetium 1999M imaging is very sensitive. This is the choice for acute hematogenous osteomyelitis, the overall accuracy being 92%. Bone scan revealing hot spot in right tibia. In right tibia, we can see the hot spot like this, black. In next MRI scan, we will see investigation of choice, titanium implant here, and if titanium implanted we can't do MRI in adults. Most common destruction of L3 and L4 vertebra. The specificity of radioactive isotope imaging techniques have improved in the evaluation of musculoskeletal infection. Technetium 9090 imaging is very sensitive. The choice for acute hematogenous osteomyelitis, the overall accuracy being 92%. MRI scan in children, distal femur, L3 and L4 vertebra osteomyelitis. We see here the white in the dark area. Here the white and dark same in the destruction of L3 L4 vertebra. And here the titanium implant. Identify the organism in osteomyelitis. Superficial swabs are of no value in identify the organism involved. If an organism is involved, we can't swab out it. If the patient is on antibiotics, specimens may give a false negative. A neutrophil infiltrate histology is diagnosis of infection. If a neutrophil level increase, it's infiltrate, not a proper. We can see that it's an infection. Multiple biopsy specimens are needed for reliable diagnosis. Multiple biopsies we will do. Specimens are needed for reliable diagnosis. General principle surgical management. Successful surgical treatment relies on the delivery of a few basic principles. These are preoperative patient assessment and clinical staging of disease. First of all, patient assessment, we will do a clinical staging of the disease. Full discussion of all treatment options with potential complications, diagnosis tests for general health, optimization of patient and treatment of comorbidities. Before operation, we will assess clinical staging, full discussion of treatment options with potential complications, diagnose test for general health, then optimization of patient and treatment of comorbidities. Then operative phase is exposure of multiple deep bone sampling. We will take sample and exposure of multiple deep bone sampling, excision of all affected tissue, intravenous antibiotics after sampling, bone stabilization if necessary, dead space management, soft tissue cover which may include plastic surgery, functional rehabilitation, continued antimicrobial therapy guided by culture results. Treatment of osteomyelitis. Treatment of osteomyelitis. Septic shock needs treatment without delay with antibiotics chosen empirically. Otherwise, the start of antibiotics should be delayed until specimens have been taken. In elective surgery for osteomyelitis, antibiotics should be stopped 2 weeks in advance. Antibiotics in osteomyelitis follow local guidelines. Amoxicillin is good for community acquired infections. Vancomycin is better for hospital acquired. MRSA meropenem may be needed for Pseudomonas. The treatment of osteomyelitis must be started before the culture. If not, then it will be severe and antibiotics should be stopped before 2 weeks. And antibiotics in osteomyelitis follow local guidelines like amoxicillin is good for community acquired infection like CAI. Community acquired infection for better is amoxicillin and vancomycin is better for hospital acquired. And meropenem, 3 drugs: amoxicillin, vancomycin and meropenem. Here the acute osteomyelitis present in children with toxemia, fever, and unwillingness to move the limb. X-rays are normal for up to 1 week, so are of no value in making an early diagnosis. WBC and CRP are usually raised. Early diagnosis treated with high dose IV antibiotics. Late diagnosis and failure of medical treatment requires surgical detachment. Chronic osteomyelitis. This is a serious condition which may affect the patient for decades. It often occurs in those with multiple comorbidities which must be managed with the infection. Chronic bone infection is best treated within a dedicated multidisciplinary team. Acute osteomyelitis present in children, toxemia, fever, and willingness to move the limb. X-ray is normal for up to 1 week, so are of no value in making an early diagnosis. Ws and CRP are usually raised. Early diagnosis is treated with high dose antibiotics, IV antibiotics. Late diagnosis and failure of medical treatment requires surgical detachment. First, in children. Second, excess diagnosis, WBC or CRP increase. Third, early diagnosis treated high dose IV, and late treatment is surgical detachment. In chronic, most people are affected and managed with infection with the multiple disciplinary diagnosis. Okay, MRI. First of all, X-ray, CT, MRI. MRI is the imaging test of choice. Then blood tests are often normal in chronic. Plain X-rays can delineate soft tissue swelling, subperiosteal reaction, bone destruction, and sequestra. CT scan are good for cortical bone imaging and for planning surgical excision. CT scan are good for cortical bone imaging and for planning surgical excision. MRI is the imaging test of choice that can be adversely affected by metal implants and can overestimate the extent of infection when there is widespread reactive edema. Okay, thanks a lot.